Hello, everyone. Welcome to the second episode or second season of Rising Stars in Ophthalmology. Jennifer, Will, and I take a lot of pride in bringing you Rising Stars in Ophthalmology. Just to give you a quick intro about the event, before we kick things off, the Rising Stars in Ophthalmology is an educational initiative that brings most of the renowned names of ophthalmology under one platform to share knowledge and discuss the latest of what's happening in our field. We believe that this platform eventually will serve and uplift the surgeons, clinicians, ophthalmic community as a whole to bring out the best in each of us, inspirationally and motivationally. At least that's what we're striving for. The first edition of the Rising Stars was launched last year around the same time, and it concluded early this year. It was made up of 9 virtual episodes featuring some of the most knowledgeable and celebrated figures in the world of ophthalmology. We certainly can't think of anybody better than what we have got this year, and we quite look forward to this exciting year, if not better. Each episode will feature one rising star and surround them by 3 celebrity panelists. Okay, by celebrity, we aren't talking about Brangelina or anything. Sorry for the disappointment, guys. We're talking about rather real heroes that really save light and save sight in the field of ophthalmology. During each course or each episode, the audience will discover that the rising stars' journey, their cases, and their experience. And this will be mixed with an interactive discussion with the celebrity panel. Apart from this, any audience that's watching this can throw in questions through the chat window. So watch out for that chat window, and both on YouTube as well as on risingeyestars.com to basically ask us, and we as moderators, Jen and I, will post these questions to the celebrity panel and the stars. The entire event and every episode will be broadcasted live on risingeyestars.com and our YouTube channel, Rising Stars in Ophthalmology. These links also will be posted on our social media handles, which I will be mentioning on the chat soon. Please subscribe to these links. Your patronage to us will go a long way in making this initiative known in the ophthalmic community. Apart from the entire episode being broadcasted live, we'll also be uploading small snippets of each episode onto our social media platform for everybody's educational tips that we bring out, the pearls that come out of the discussion. The only thing left to do here is now to thank the sponsors of the Rising Stars, without which this wouldn't have been a reality. So thank you so much for each of you who are sponsoring us. And I'd like to take a personal thank you to each and everybody viewing right now, because if there's nobody viewing, there's nobody watching, right? And last but not the least, I now must do the honors of, I must call upon my favorite co-moderator, Jennifer Lowe, to introduce the star of the show, celebrity panel, and our ever so gracious sponsors. Jen, all yours.
Thanks so much, Ashvin. Although you saying that I'm your favorite co-moderator is probably like saying your only sibling's your favorite sister, right? But thank you. Thank you for saying I'm the favorite. But in all seriousness, it is a pleasure to be able to co-moderate this fantastic season with you. And it was a really amazing experience as well last season. So I look forward to 9 great episodes. So without further ado, I did want to kick off our meeting first by thanking our featured sponsor tonight, who is Allergan. And on behalf of Allergan, Dr. Lisa Nijam will be saying a few words. And as many of you already know, Dr. Lisa Nijam is a powerhouse in her own right. She is the CEO of Women in Ophthalmology and the medical director of Warrenville Eye Care and LASIK in Illinois, as well as she's recently founded Real World Ophthalmology, which we'll be learning about very soon. So I'd like to give the floor to Dr. Lisa Nijam.
Thank you so much, Jen. And thank you guys. You guys have done such an amazing job with Rising Stars. Season 1 was amazing. And I have no doubt that season 2 is going to be as amazing, if not even better. So congratulations on that. It's a privilege to be here tonight on behalf of Allergan. And I just want to take a few minutes and talk to you about building community and trust to advance ophthalmic care, which Allergan has done over the past 70 years in ophthalmology, which is pretty amazing when you think about it, because how many ophthalmic companies, have been around for 70 years, let alone contributing to our field and helping us take care of patients for 70 years. So that's a pretty astounding feat in and of itself. And when you look to see how did they do that, I think two things come to mind. One is that they've been really good about identifying and reaching out to us to serve our patients' unmet needs and creating these emerging markets and shaping the markets by bringing innovative products to help us take better care of patients. And they did this most prominently, as you know, with Restasis 20 years ago. And hard to believe, 20 years, but Restasis has been around and they've been consistently providing us. It's been still the number one eye drop for dry eyes that's prescribed. And it's not an easy molecule to work with. You know that cyclosporin is difficult, it's hydrophobic, but Allergan, that's where they excel. They figured out the formulation. They have a stable formulation, they've been able to provide us consistent product to take care of our patients. And that's why they've remained the market leader there. And they really shaped and carved that dry eye space where we didn't have options for treatment before. And now it's really exciting to see what they're going to do in presbyopia, which is sort of the next big thing in ophthalmology. They're leading the charge where we have 128 million patients in the US who are presbyopic. Think about that for a minute. 128 million patients. They're all in your waiting rooms. And they're looking for better ways to be taken care of with their presbyopia, because all the market research shows that patients are frustrated, that it's something that 96% of them feel that it moderately impacts their quality of life on a daily basis, and 46% feels it severely impacts their quality of life. And so it's a really problem that's just getting worse or will become more prominent as even our millennials, I can't even say this, even the millennials are turning 40 now. So this is something that we're really excited to see Allergan leading the charge. This is an opportunity for us to help educate our patients on presbyopia. I know myself, I've had more concentrated conversations with patients on presbyopia in recent months. And it's been great to see how intrigued patients are and how they lean into conversations and are very excited about understanding their condition and, being able to better figure out how to better manage this in the future. So I am really happy that Allergan is leading the charge and looking to shape the market in presbyopia. I think it's going to open the doors for us as far as what we can offer patients and how we can treat patients and educate them. And it will overall elevate patients' health. So I hope you'll join me in congratulating Allergan on looking to be the leader and serving as a leader to shape this new market in presbyopia to elevate patients' health and help us better care for patients. Thanks.
Thank you,
Great.
Lisa.
Thank you so much, Lisa. We appreciate it. I did want to take a moment as well to thank all of our sponsors for season 2. And we have a nice slide here. So I wanted to personally, again, thank Allergan, Sustain Ilux, Elcon, Dompe, Vices, Centricity Vision, Avellino, Biotissue, Zeiss, BVI, LSR Vision Technology, Sun Ophthalmics, and Tarsus. Thank you again for all your support and all that you do. Okay, so next up, I would like to share my screen and one moment, please. Actually, I'd like to start off by introducing next all of our panelists. So let me hit the slideshow here. Okay, so as everyone knows, this is our season 2, episode 1. Topic tonight, building community and trust to advance ophthalmic care. And I'd like to introduce all of our celebrity panelists as well as our rising star speaker. So first up, we have Dr. Renee Bovelle. She's in Maryland. She did medical school at UCLA and residency at Yale. We asked all of our celebrity panelists to share some fun photos of themselves. Dr. Bovelle, would you like to share just a couple words on some of these photos?
Okay. Sure. As you see, I stick with the eyes. I love going to these conferences where we can wear the funny eyeglasses. The first one is me in the sun, in the Christmas tree eyeglasses, and my friend Rob Campbell. The second one is a little more serious, showing that I got vaccinated, and we all know how important that is. And the third one is me and my mom at another conference. She's got the peace sign and I have the glam glasses.
Oh, that's so cute. And your mom really does look like your sister. I'm very impressed. She is very young looking. I wasn't sure who that was in the photo. That's
Yes.
amazing. Well, good. Well, thank you again for sharing your wisdom tonight, Dr. Bovelle. Okay, so next up here, we have Dr. Rosa Braga-Mele from University of Toronto, across the border in Canada, which I fully support. I'm also Canadian, so yay. So Dr. Braga-Mele did medical school in University of Ottawa and her residency in University of Toronto. And she has some awesome photos here. I know she let us know that she coaches basketball. She's an expert cyclist and also an experienced weightlifter. Would you like to share some stories, Dr. Braga-Mele?
Sure, but I don't have the pictures up. I just have a photo of me up. Did your screen move, Jennifer?
Oh, it
there we
did
go.
move.
Oh.
Okay, how about that? Can you see it now?
Yeah, so this is before COVID hit, literally just before COVID hit. This is my son. He's number 48 here. And I've coached all 3 of my boys. I'm a professional Canadian basketball coach, certified basketball coach. And all 3 of my boys through grades 4 through grade 9, I've coached them, and we just won the championships, and then COVID hit. And there hasn't been sports since then, but all 3 of my boys have won championships in their grade 6 year with me as their coach. So it's a great feat against all the schools in the greater Toronto area. And then I cycle a lot, but my biggest thing lately is that I am a nationally ranked bodybuilder, hoping to get my pro card in all natural women's physique. So I'm prepping right now for our competition in November, end of November. So I hope I don't get grumpy and hangry during our talk here, but I doubt I will. But anyway, it's been great. Ophthalmology is my hobby and bodybuilding is my profession nowadays. So it's definitely interesting.
That's really awesome. I know the restrictions on diet are really tough, so I'm very impressed. So that's wonderful. Okay, well, thank you. Next we have, last but not least, we have Dr. Cynthia Matossian, who's the founder of Matossian Eye Associates in Pennsylvania. She did medical school at Penn State and her residency at George Washington. And we have a lot of fun photos for Dr. Matossian. Cynthia, would you like to explain any of these awesome photos?
I would love to. And again, thank you very much for inviting me. And Jen, I don't see the pictures either. Maybe if you can move to the next slide.
Let me see
The
here.
pictures are cut off.
Okay. How about now?
Oh, there we are. Okay. I'll start with the very first one. I was invited to give a presentation in South Carolina for women in ophthalmology. And Carl Stonecipher, who's a colleague of mine, snuck in wearing a wig, pretending to be a woman to join this meeting. So that was a big hit. That's in the middle. That's a picture of my husband and I hiking in Sardinia. Another picture of us riding horses that was in Arizona not too long ago. And the bottom picture is 4 generations of women in our family. My mom, 97, fully with it, our daughter, and my granddaughter, who is a year and a half.
Oh, very, very cute. Thank you, Cynthia. And I'm glad you explained Carl's wig, because I thought he was trying to be like a British judge or something. I didn't realize he was actually trying to pose as a woman. Okay, great. Thank you for the clarification.
Yeah.
Okay, so great. Well, last but not least, I'd like to introduce our rising star for the evening, Dr. Himani Goyal. She's a clinical assistant professor at NYU, and she's actually chief of service at Woodhull Hospital. She did medical school at UMDNJ and her residency at SUNY Health Science Center. And also she did a fellowship at NYU. And Himani has some amazing photos here. The most impressive one, I think, is the one on the left side of the screen with a huge lion. Dr. Goyal, would you like to explain?
Oh my God, that's a photo that I didn't even send you. That's crazy. Oh my gosh, this is from 2013 or 14. We actually went on a safari in South Africa and got to do what they call a catwalk, and take these awesome pictures. I don't know, in hindsight, it seems like it was kind of a risky thing to do.
That's not Photoshop. That's actually you next to the one.
No, it's definitely not. Definitely not.
Okay, that's pretty impressive.
Yeah.
Okay, great.
And that second photo is just my COVID vaccine shot.
Oh, good. Okay, we have a couple more photos to share, so don't despair. I think I see some cute kid photos here if you'd like to share or explain.
Yeah, I think there's just a little lag in the
Oh. Yeah, let me try again there. How about that?
Oh yeah. Okay. So this is my family. We actually got to celebrate Holi like we used to in India. After years, I think I was actually Kendi's age, who's my son. He's 4.5 years old now. And I think the last time I really celebrated Holi like this was when I was in India at that same age. It was really amazing to get to do that in Brooklyn and then not have to clean up the mess after. And these are my kids just being kids. My daughter's name is Tatiana. She's 6. And that's a photo of my family on Father's Day. And then the last pictures, my husband and I on a date night for our anniversary. It was actually during COVID time. So we actually got to go out after a very long time at an outdoor venue to have dinner together.
Oh, good. Well, very nice. All right. Well, thank you very much. I'm going to stop sharing my screen and we'll let you take it away, Himani.
Oh, awesome.
We're looking forward to your presentation.
Great. So I'm going to start to share my screen. And awesome. Well, thank you all for joining us tonight. Good evening, good morning, depending on whichever time zone you're in. Thank you all for being here. Building community and trust to advance ophthalmic care. This is something that's actually really dear to my heart. It's something that's on my mind with every interaction every day, whether it's when I'm with my patients or my time with my residents, with my staff and my colleagues, or even when I'm with my family and my friends. Honestly, it should really just be building community and trust to advance ourselves as humans. There may be some times when I'm like really vested in what I'm teaching you and get emotional. So just bear with me. I will try to keep this under control. And as we go through some of these things, for some of you, it may come more naturally and you may be able to relate to it very easily. And for some, these concepts may be very new and may take some effort and some practice to actually incorporate into your lives. So first of all, there were a few motivating factors for me just going into this. First, there was the pandemic that came into our homes and it was really scary. We really had to learn how to treat it from scratch. And then we actually ended up having a grand rounds about a month into the pandemic from a frontlines doctor from China. And it was amazing. And it made me realize how important it was to have that connection. And just from even building the community and the connection between all the hospitals in New York City, because we were the epicenter, or just all of the departments coming together in our deployment to take care of COVID. It really took a big team effort. And the next thing was just kind of as the pandemic evolved and time went on, we really started to realize the racial inequities that started to unmask themselves in the US. The distrust was really apparent in our criminal justice system and in our healthcare system. And the lack of connection within our communities really still exists today, as it has created a lot of fear for vaccinations. And it's created this sort of syndemic situation where we have two major events like COVID-19 and the distrust or the racism that's causing a higher proliferation of the disease and a higher disease burden in the US. And so besides this happening, the second motivating event for me is that I happen to be surrounded by two different types of colleagues, those that believed in me and then those that doubted me. This opportunity today is given to me by the people who believe in me. And because of it, I'm going to grow and I'm going to learn more. And I've learned so much more and gained so much more confidence because I was lucky to have people in my life that believed in me. Whereas when I was around the people that doubted me, it made me doubt myself. And I was scared to try new things or teach new things. And I didn't have the support to explore my ideas. And I almost had to do what I believed in despite their discouragement, which I think is a risky sort of setup. And so just realizing the two different ways of feeling and growing as a person. And while this is all happening, I have a strong relationship with my residents, and I realize that 12 years in, it just keeps on getting better and better. And that's something that may be unique. And I attribute this to my belief in them. So, bringing all of this kind of back to ophthalmology, rising eye stars came during the time of a pandemic to keep us connected. And we as ophthalmologists actually do an amazing job of this. And the global presence on this webinar is proof. But despite our global connection, at the local and regional levels, there's actually still quite a bit of disconnect. And racial, gender, and sexual orientation discrimination are everywhere. And our medical education is full of subordination and implicit biases. There's so much to be gained from bridging these gaps in our everyday interactions. And our goal today is to help all of you kind of teach you the tools that you'll need to make an impact and to change, to create more connection. And I will elicit the help of my celebrity panelists. Because between these conferences is when we can actually make a difference every day and start to make an impact much more quickly than just coming together once in a while for conferences. So the first step is to become aware, right? Why does this distrust exist? And that kind of comes from the history of slavery, of policing and scientific experimentation on Blacks and Native Americans in our country. It's really mind-blowing. It's crazy. I'm going to list just a few of the studies to bring this to our hearts. The Tuskegee syphilis study, which was just completed in 1972, which is not really that long ago, there were 400 Black men who were intentionally not treated for syphilis just to watch the natural course of the disease, even though a treatment actually already existed. Henrietta Lacks was a Black woman with cervical cancer whose cells were used for research for 70 years. And not once was her family or herself compensated. And those cells for 70 years let us develop drugs for HSV, leukemia, influenza, HPV, and even more. And then the latest one was a study that was just published in 2016. And I'm going to read this title to you. Racial bias in pain assessment and treatment recommendations and false beliefs about biological differences between Blacks and whites. And there was a reflection on this just last year that 40% of first and second year medical students endorsed that Black people's skin is thicker, than white people's. And the trainees who believe that Black people are not as sensitive to pain as white people are less likely to treat Black people with pain appropriately. It's just mind-boggling that this is actually still existent today. And the Association of American Colleges actually put out this statement. Racial and ethnic disparities in pain treatment are not intentional. Instead, inequities are the product of complex influences, including implicit biases that providers don't even know that they have. And along those lines, there's sexual discrimination. In many cultures, women and children are viewed as property, just as slaves were in the US. And even though we have more rights now, we are still not equal. This was a study that was just published in 2021 by Lama Al-Aswad. Female ophthalmologists earn significantly less than their male colleagues in their first year of clinical practice, and these salary differences persist after controlling for demographic, educational, and practice type. And the differences lead to a substantial loss of accumulated earnings over an individual's career. This is something that I feel like I can relate to. You know, I am just as educated as every male person in my family, yet there is a doubt that the decisions that I've made for myself are as good as the decisions that they would have made for me. And just along these lines, I wanted to bring in Dr. Braga-Mele. You know, are these issues also present in Canada, and how do you relate?
So, thank you for asking my opinion. I am an ethnical woman, just not a woman of color, but I have faced a lot of sexual discrimination and within medicine, both in Canada and the US and abroad through my career. I just did a podcast for medical students actually about how it feels to be a woman in medicine and how to pave the way for other women in medicine just last week. And are they present in Canada? Yes, they are. It's a smaller microcosm of the US. Obviously, our population is less. I think we are a more heterogeneous community where we have more of a blended community, but we still respect the religion, the rights, the color of people within each of their own communities. So we don't try to assimilate people in Canada. Every community is one of its own if it wishes to be that. But no, I don't think anywhere in the world does racism not exist and does sexism not exist. I think it's just different degrees and perhaps more visible in the US just because your population is so large and there are so many more segregated areas. But I do see it very clearly in everywhere we go. And I think the hardest position to be in would be to be a Black woman today, because I think that is still the most difficult and challenging position to be in. And I think it's important for us as women to stand together. And I think it's important for I don't know if it'll ever be eradicated, racism, but I certainly hope that we will see less and less of it as time goes by, or at least it won't be as prevalent or as much of a decision maker.
Thank you so much for sharing that. Raising awareness, right? I think is exactly Absolutely. What we need to start. And then, you know, to continue on the long-term effects of discrimination of the Black physicians, it continues during residency, during fellowship, and when they're in practice. And they feel isolated, which is the opposite of being a part of a community. And they're punished more harshly than others. And then this sort of brings up to me, you know, don't we see this in our younger physicians too? Like residents or younger faculty punished more harshly than maybe our senior faculty, and they don't have as much of a voice and they're not as much of a part of the team. And the same thing for females. They're isolated. Maybe they don't have as much support from their families or colleagues. And so we lose them in our profession. This leads to attrition, and those who are not represented in our profession then lead to less of us being able to serve those patients in our population. I just bring up this chart to kind of highlight the numbers in terms of how many minorities are actually in ophthalmology, and there is actually a lot of work for us to do here. Oh, sorry. So Dr. Bovelle, I actually really wanted to bring you into the conversation at this time because I do feel like there was a webinar that you did recently where it was mentioned that, you know, Black patients are more likely to talk to Black patients. And then I added to their young patients are more likely to talk to young physicians, or female patients are more likely to talk to female physicians. And building that connection takes a lot more effort when it's just not naturally there. But I wanted to just get your take on how this plays a role in ophthalmology for us.
Yes, it does, Dr. Goyal. And I am so glad that you wanted to highlight this. And I'm also very pleased that Dr. Lowe and Dr. Agarwal and Dr. Trattler felt that this topic was important enough to present. I mean, we all love talking about all the new MIGs and all the new innovations, surgical innovations coming along. And I just want to say I'm glad that the team felt that this is equally as important, because we have to make sure that all patients have access to all of these new innovations and developments that we have in ophthalmology. I think the most important thing is to remember that we're treating human beings, right? So as a human being, I have to remember these aren't just a set of eyes that I'm treating. There's a person attached to those eyes. This is a lot. And I think that I don't want people to come away thinking that only Black patients can treat Black patients, only young patients can treat young patients. That's not what it is. I think it's that I'm Black, African American. When I see another African American, I see their humanness and I recognize that, and others may not. And you pointed out some reasons why. There were some examples, you know, people don't feel pain, there's stereotypes, or is the person malingering, all of that. Or in our field, oh, well, yeah, pretty much all Black people have glaucoma, so maybe it's not that much of a deal. You know, we'll try some drops, try different things. If it doesn't work, well, that's just the way it is. Black people get glaucoma, maybe I don't have to try as hard. So how do we deal with this? How do we get to the human part? What I like to do, as you mentioned, I'm in the DC metro area. It's very international. My staff is international. My patient population is international. So I try to find something when I'm dealing with international patients to put them at ease. It may take an extra minute. If I know what country they're from, I may mention, hey, I've been to your country, I enjoyed it. Or, hey, I haven't been to your country, I'd like to go there. Or these are just things that come to my mind. I happen to be a foodie, so I can always talk about food. And again, here in DC, we have pretty much every kind of restaurant there is, just like in New York City and other places. So I may say, and especially let's say I have a diabetic patient, I may say something like, hey, I know, you know, if I'm talking to someone from Nigeria, I know you have great food, you eat it with a lot of rice. You got to remember, you know, for diabetes, you may want to cut back on the rice and try something else. And then I usually refer them to a nutritionist or something. But I try to find something to connect. And it doesn't mean for, you know, I'm trying to look at each person, a Jewish person, and try to say something that connects with them. No, you may look at a lot of patients wear t-shirts. What t-shirt do they have on? Are they for Dallas? Well, obviously I'm for the Washington team, and I'll say, hey, I'm going to treat you even though you're a Dallas fan, or something silly, just something to connect. And I think that first 30 seconds helps. Additionally, it's important. Don't just think that maybe people may think African Americans or Hispanics, oh, they just don't take their drops. What's wrong with them? They just don't do it. Maybe ask why.
Yeah,
right?
We're going to get into a lot of the tools that we can use to connect, but I think you've actually mentioned one of the key words is connecting. And also just sort of the patients see themselves in you. And there is that trust. And for those that don't, you actually take time to build that trust. And we're actually going to get into a lot more details on how to do that. And I thank you for sharing all of those tools with us already. We're sort of starting that conversation on how to go from awareness to actually starting to shift into to making change.
Thank you.
And so, just as Dr. Bovelle has already started to teach us, how do we bring this knowledge now, this awareness of where this distrust comes from, and start to make change? And this is where I want to introduce the term restorative. What it means to be restorative is simply to build community. Human beings relate to each other, and they need to be connected. All these powerful words that Dr. Bovelle just shared with us. What actually motivates people to do the right thing is a feeling of belongingness. Again, just so many things that Dr. Bovelle brought about, compliance with drops. And there's a connection there. They will be more likely to do those things because they understand. And there's something called fair process. It's about engaging, explaining, and clarifying expectations. And if you think about this doesn't just relate to our patients. It actually can relate to every relationship, our patients, our residents, our colleagues, our mentors, our staff, our industry representatives, other specialties that we interact with, our optometrists, but also our family, our children, and their teachers. And this is about, we are in this together. It's about that feeling of being in this together. So let's talk about patient care. It's almost as if Dr. Bovelle read my mind in terms of bringing all these things up. And I'm actually going to put a lot of these points up already because I want to just go through them and you can sort of read through it if you're with me. How do we see our communities? Do we see them as partners or projects? And I want you to think about these. Are we their saviors? I mean, we are more educated and we know what's best for them. And we did spend most of our lives learning, and we are experts in eyeballs. But can we actually take a step back and gain their trust? Treat them like partners using fair process. Can we have a relationship with our patients every step of the way? From the moment they step into our office, the first person that greets them is trained to treat them like a human being. Then the technicians, then the doctors, all the way through surgery day, and then after. And then can we broaden this to engage their whole community? And, are we saying we have goals for this community? We have goals for them. Or are we actually working with them and trying to connect them? Are we coming in to say, well, you better do this, or actually trying to be one of them and connect? And now that we understand where the distrust comes from, will it allow us to change our mindset? And how do we relate to somebody who gives us attitude and is mad at us, even though we're trying to help them? Having empathy, a heart at peace, and giving them a voice. I put interpreter here next to giving them a voice, and it's not just to give them a voice if they don't speak the same language, but there is something to be said for that, because the sigh of relief that comes over a Spanish-speaking patient when I speak to them in Spanish is just visible. Or when I get, a translator on MarDX, which is a virtual translator, it's just visible. So that is just something I want to bring up. And Dr. Matossian, I wanted to bring you into the conversation now. How does this concept fit into your practice?
Well, I'm so glad that you brought up this topic, Himani, because it's important in every setting, in every practice, whether it's academic or private. So the way I fit it into my practice is that we put the patient front and center. So we actually called our practice patient-centric. We have it in our mission statement. Every week when we had our 1 hour staff training, we read the mission statement. We went around, different people were selected randomly to read it, and we described what it meant to put the patient first. And everything kind of, if that was the bullseye, targeted around and kind of spread out from there. And it's all the things that were mentioned: treating the patient the way you would want to be treated, recognizing that not everybody understands instructions or the way you're explaining a particular diagnosis the same way, working with their caregivers and family members. So it's really embracing the patient, his or her community, and maintaining that patient-centric focus is critical, and reinforcing it with your colleagues within the practice, within their staff, who is your employee, basically, or all the staff, and everybody from billing to administration. So it takes a village, but it constantly requires reinforcement and underscoring, because it takes a lot of time and effort to remain patient-centric and deliver what we're saying.
Definitely. Thank you. And so going from our from our patient care to now our relationships with our residents and colleagues. So building relationships, there's this term called propinquity, which is about proximity, creating kinship. And meaning, if we keep each other close, we can actually influence each other and learn from each other and start to form a bond. Getting out of your comfort zone and giving everyone a chance to speak up, and creating an environment where open discussions are safe, sharing stories and really connecting emotionally, having a mutual respect for each other and celebrating each other's accomplishments. All of the things that the celebrity panelists have already touched upon. And there's some overlap here in terms of, building relationships with colleagues and with our residents. And I think that the relationship with our residents is actually extremely tender, because there's a hierarchical kind of a relationship there that needs a little bit more care, and trust, right? Giving the residents some independence to learn and figure things out, and knowing that they may fail, but they'll learn from it, and creating an environment where mistakes are okay. This is so important. Having a friendship and empathy with them, and shifting from this mindset of you can do nothing right to you can do nothing wrong. And sort of in that realm of making mistakes and having it be okay to make mistakes, I wanted to sort of go into conflict resolution a little bit, because mistakes and conflicts are inevitable. And the way that we actually process them and navigate them can actually really affect how we let somebody grow and change for the future. And so the difference between a punitive measurement and a fair process. In punitive measurements, we're basically saying we're mad and here's what we're going to do to punish you. Whereas if we're being restorative, we say, hey, here's how people were affected and here's our needs to make things right. But let's make sure to hear from you as well. And because we've built a strong community to begin with, we can have this conversation. And punishment as a negative kind of rebuff on a person actually registers in our brain as a physical pain. And we think about negative remarks way more than we think about positive remarks. And this actually makes us lose our mental efficiency. Whereas if we were actually involving people with empathy and actually telling them how we feel and listening to how they feel and letting them be a part of that corrective process, the positive approach actually broadens their ideas about future possibilities, and it creates an open mind and opens it to innovation and allows them to be able to cope with adversity and high stress better in the future. And so, Dr. Braga-Mele, I know you work with residents a lot, and I think this is one of the things that I feel like I can relate to you with, but you've actually been in practice for almost 25 years, I think, and you're still going strong. And I really wanted you to give us some of your pearls for building that relationship and teaching your residents.
So I've been teaching residents for 24 years, actually, we have to remember that our residents are going to become our colleagues. So we're trying to build not only good surgeons, but good people and a good community that we want back out there, that are not only going to be our friends when we need to refer our patients or when we might need help ourselves, but also our friends in life. Perhaps some of my closest friends in ophthalmology are previous residents of mine that I have developed relationships with over the years. My pearls are, one, to be very honest with residents. I am honest and upfront. I'm honest and upfront with everybody I meet. I think I'm well known for that, to shoot straight from the hip, but I definitely shoot straight from the hip with my residents. And so I read them the riot act when they come into my OR in a very kind and friendly manner. One is to treat the nurses like gold, because the nurses are number one, whether we are in the OR or in the clinic. And that is the number one pearl I can teach them, because if the nurse is on your side or the clinic staff is on your side, the day will go so much better for you. Start learning that now and perfect it, because that is pearl number one for them. Pearl number two is listen. We have one mouth and two ears for a reason. So we should listen with our ears and listen to our staff. Before we think we're better than, or I've done, 60 cases, I must be amazing and great. But if they can listen, if they can show empathy towards the patient, and if they can learn from their mistakes, then I never fault them, ever. I am very calm in the OR. It is my Zen place. My residents do a lot of cases. I've won the University of Toronto Silver Needle Teaching Award 5 or 6 times. I've won community teaching awards here at U of T, and I've won a national award in teaching as well, because I love teaching, because I think it makes a difference in our community of ophthalmology if we're good teachers and relay our skills, both communication skills. I do have my master's of education as well in communication skills and ethics. And I think it's very important to relay to residents exactly what we expect of them, to have a friendship, but kind of like you do with your children, right? We're not really our kids' friends. So during the residency, my residents still have to respect me as their mentor and show that respect. Definitely the minute they graduate, we're friends and they call me Rosa. It's never a problem. But, I guide them the best I can, but I'm not infallible either. I teach them. I just did a case on Quickstand Chronicles where I was teaching my resident how to do a great case and something went wrong. And so I have to be willing to say to my residents, look, they'll sometimes find me laughing. Okay, this is how you not do a case, right? When I'm doing a case. And so if you can laugh at yourself, and when I say to my residents, and I had this from a very great mentor, and he said, it's not how you screw up, it's how you clean up. And it's remembering what you've done wrong so you don't do it again. And that's what makes you from a mediocre surgeon to a great surgeon. And that's what takes you from a good resident to a great resident. And that's teaching them that I have certain expectations from them. If they want teaching from me, then I have expectations from them on patient care afterwards. But I'll have to say at U of T, our residents are amazing. And I think they get that from a lot of our teachers. We have a lot of good mentors here. But just laying down the ground rules, being honest, holding their hands, holding their shoulders in the OR, and helping them through it. And not always, we talk about punitive conflict. When they make a mistake, don't get them up right away. you might want to let them think about it a little bit and help them through it if they're at that level. Depends. Everything changes the level of training they have. And the higher training they have, the more complicated, challenging cases they get to do of mine, or more refractive cases. And so you also have to be aware of your residents' learning experiences. But residents are our future, and that's what we forget. And I teach, and people go, why do you teach? I teach, Himani, 100% of the time. I'm never without a resident in the OR anyway. And I do run a clinic with residents and medical students. And so I teach because they're our future. And, I can see 30 patients or 50 or 60 patients a day or do this many surgeries. But for every resident I teach, I'm broadening that scope more and more and putting my mark. And my biggest compliment is when residents come back and say, I was in a case, Dr. Braga-Mele, and you were on my shoulder, and it was your voice I heard telling me what to do when I was having a hard time. So I hope I'm leaving a legacy. And if not, at least I hope I'm helping a lot of people. But the one benefit I've had is I've made a lot of great friends out of this, and people who definitely have my back. And so it's been a great experience for me.
That's amazing. Thank you so much. That's so amazing.
Fantastic.
And so, here we are. Now we've got our awareness, we've got our tools, we've got all this advice that all of our panelists have taught us. And how do we actually hold each other accountable to reaching, to making change, and what are our goals? We recently had grand rounds with Mildred Olivier, and, she basically laid it down, build a team that reflects the population around us. Diversity matters because that's what's going to help us eliminate health disparities. And we need to shift from being an exclusive sort of specialty to an inclusive specialty, and making a conscious effort. Implicit bias training, all of us are susceptible to stereotypes and bias, and that's, our very first thought. But what's more important is not our first thought, but our next thought. And what's critical is what we do with that second thought. So think twice, interrupt racism, make restorative practices a part of our education, a core part of our medical school training and in our residency programs. And let's teach our attendings, because then we can pass it down to our residents and our students. There's actually some changes in our ACGME requirements. This is our accreditation for graduate medical education, which basically will be looking for us actively making it explicitly clear that discrimination will not be tolerated. And we need to actively recruit diversity and expose to our community and increase interest, even at the level of elementary school. This is where it needs to start, because this is where the disparities start. And also to realize that board scores or first-time pass rates actually don't correlate with any clinical skills, and that's been proven. We need to have a more holistic approach to recruiting candidates into our programs, and that needs to be standardized, not just standardized board scores. And we need to be able to provide the support to those that may not have had the same privileges as others growing up. And, despite having all of these tools, the awareness, there's still going to be barriers. Role modeling is a very powerful influencer. And if our authorities, who are our mentors, our parents, our police officers, have biases, it will be hard to break that. And there's something called identifying with the aggressor, the fear that if you actually stand up against an authority, that you're going to be the target of their hatred and maybe even their abuse. And it's easier to go along and get along than it is to actually stand up for something different. And then also the race baiting and self-fulfilling prophecy, which is it's really disheartening, because, minorities can get provoked by authorities, and then they'll act out of anger or despair. And it gives the authorities a justification to take force against them. And this is all really heavy stuff. And I know, Dr. Bovelle, I keep bringing you in when it's related to this. And I think that just having listened to you on the OWL webinars lately just really make me think of, I want to know what you think are the barriers for change as you hear all of these things.
Sure. And you have brought up some really challenging issues to discuss. And I think the most important one you brought up was ourselves. We all have some type of implicit bias, including minorities, African Americans. We all have it. But I love what you said. What's the second thought? And I think if we can't acknowledge that implicit bias within ourselves and say, hey, I have my own work to do, then it's not going to change. Another barrier to change is, I know we're rushed. We have a lot on our plate, but taking the extra 60, 30, 90 seconds to make a patient feel more comfortable is very, very important. And you may get that 30, 60, 90 seconds back, because then that patient will feel so comfortable with you that they will refer their family and friends to you. Another barrier to change, I think, is the hierarchy. And I think because our specialty is one of the tougher ones to get into, we kind of feel special. And we only think that whoever we think is special should be a part of it. And you brought that up a little bit, and I think that's something that we have to change. Who is special and why? Who is allowed into ophthalmology? Who is allowed into medical school? And why can't it be broadened? And if someone shows an interest, they're willing to put in the work, maybe we can help them out a little bit. And I'm not saying lower our standards, but I'm saying maybe help that person, give them a bit of guidance.
Thank you so much, Dr. Bovelle. You're really just reading my mind on a lot of things.
I'm sorry.
No, it's totally awesome. I love it. I love it. This is exactly, thank you. It's perfect.
So,
I wrote down.
Himani, sorry, I'm stopping you, but on that same note, I think there's been a question which I think it's on the platform. And the question is, does anybody know this answer? What's the current and the future status of the diversity amongst ophthalmologists in the workforce? Any thoughts on that? Do we know the stats on this? Or?
So we have the stats for the US. I don't have it for international, but I did present that on one of my slides earlier. Off the top of my head, I think it's 2.5% are Black, whereas 6.5% are minorities. But only 2.5% of those are Black. And I think that the number of Native Americans is minuscule. It's less than 1%, 0.0 something.
Right. And Rosa, to you, one question that comes up is, can a IMG, that is an international medical graduate, have a chance to get a spot in ophthalmology residency?
Yes, absolutely. We have one spot a year reserved for an international medical graduate at U of T, for sure. I'm not sure the other residency programs across Canada, but at Toronto, I always have, for the last 5 or 6 years, we've had IMGs who are stellar, actually. Residents that come from across the world. We always have 2 residents that are externally funded as well. So we have residents typically from Kuwait or Saudi Arabia, that are externally funded as well. We also have a very strong resident fellowship program at U of T from everywhere around the world. But yeah, so our residents are generally 3 or 4 from across Canada, 1 IMG, and 2 externally funded at U of T. And then many of the others that are a bit larger, like I think Montreal has the same, but some of the smaller ones do not. But yes, IMGs can get positions.
Fabulous. Thank you so much. And Artem, if you're watching, that's the answer for you.
Thank you for this
and
question.
With Rosa would be mind-blowing. I can.
They won't even let me get a fellow. I used to want a fellow. And because I'm such an integral teacher of the residents, no one will let me get a fellow or start a fellowship program. So the residents don't lose teaching. So come on by.
That's awesome. Thanks, Rosa. And thanks, Ash, for those questions. So, the impact, just in terms of building community, a couple of things that come to mind is, improving our relationships with optometrists and the emergency room doctors. If they, trusted us more than they trusted the internet, maybe they wouldn't do things like sending a patient home with tetracaine and CMS, just bridging that gap. And there's always been this disconnect with our reimbursements. And if they could actually come and spend some time with us and actually be there before we start to figure out how much we should be reimbursed, and just connecting on all of that. And so, Dr. Matossian, can you share some of your thoughts on how we can make an impact on our profession by building community and trust?
Just a small reminder about the timing. I think we need to cut it short in 5 to 7 minutes. We need to bring it all together. Okay.
Excellent. So Cynthia, you have like 1 minute.
I'll be very quick. So many wonderful pearls were already shared. Vision is one of the most revered senses, and we are so fortunate to be ophthalmologists. So working with anybody who comes in contact with us, whether they are an optometrist, a medical student, a resident, a fellow, a nurse practitioner, anybody in our sphere of influence, if we can show them the passion that we all have had for our careers, I think that is very contagious, and it will go a long way to spin a very positive view on ophthalmology, optometry, and the eye profession entirely.
Awesome. Thank you. Totally agree. So I want to just bring everything together. There is a spoken word. In full disclosure, this was actually written and spoken by my husband, but I think it actually brings everything that we've talked about today together. So I really just want you all to sit back and listen to how it starts with our children.
A global pandemic forced us to distance. Feeling empty, we started to listen, realizing something essential was missing. Scientists said that's not our natural condition. In order to survive, we need social connection, a community of empathy, trust, affection. Plus, I should mention, people don't do us right just to avoid incarceration. They do the right thing due to their interrelations. Being part of a community brings an obligation, never to cause any harm, damage, or violation. Go ahead and check what the stats say. Start with the researcher John Brathwaite. Google him. He studied those guys we label thugs and hoodlums, and it turns out they're not permanently doomed. It all depends on whether we integrate or exclude. It comes down to how we educate our youth, because let's face it, school discipline as it stands is racist. And the idea that zero tolerance rules improve schools is baseless. The originators of these ideas remain faceless. Meanwhile, on a daily basis, our students become inmates and patients. Educators hit standardized test goals and stay complacent. But when challenged about the quality of student-teacher relationships, they get evasive. Our children's need for social connection is being rejected. And to not strengthen a community is to disrespect it. This is quite literally, for many, a life sentence. Because what really happens when a child is suspended? Check it. A kid sits at home for 4 days playing Fortnite. When he returns to school, we're shocked he still can't comport right. Y'all know suspension isn't actually a support, right? Oh, you thought that would fix the problem. Well, that's a short sight. Oh, don't twist my words. I didn't say have no consequence. We need restorative justice. It's common sense. Don't be a suspend first, ask questions last apologist. Anyone who's ever loved a child can follow this. Forget Confederate statues, our schools are racist monuments. And this is life and death, y'all. This is bigger than politics. The current system will continue to destroy till we abolish it. Take a second and ponder it. Would you impose such a system on your own progeny? Doubtful, obviously. And therein lies the hypocrisy. Schools are more devoted to order than to justice. That's what all the fuss is. Seriously, have we forgotten what love is? Instead of talking about love, the government says law and order. There's no money to build communities, but we're building a wall at the border. A man is assassinated by his so-called protectors, and we lash out at his supporters? Nah, that doesn't hold water. If human connection is a necessity for life, we gotta stop pushing our people out and unite. We don't heal the world by pushing bad people away. So who can you connect with today?
Thank you guys for listening to that. And I just have one last slide to share. And this is an analogy that sort of came up when I was reading one of my children a bedtime story. The sun and the rain are opposite ends of the spectrum, and they create everything that allows us to exist when they are in parallel. But when they're actually in the sky together, they make something incredible called a rainbow. And diversity and inclusion will lead to innovation. So if we actually listen to propinquity and bring people together in the same room, we can make our own rainbows. Thank you.
Beautiful.
And these are some of my resources.
Thank you, Himani. Thank you so much. Can we stop the share?
Oh, yeah.
Perfect. That was a really, probably a heavy topic, but I think it's such an important topic to talk about, especially at a time like this, when we are all facing the global pandemic. But having said that, Himani and three of you, you guys did such a swell job of putting it all together, putting those pearls out there for all those people who must be facing these issues and, helping them through the journey. And probably I call it a journey because there's no end to it, right? It still keeps moving. But thank you everybody for patiently listening and taking part in the discussion as well. We're actually humbled by the support that you've shown us over the last 1 year and continue to show us. Just remember to follow us on our social media handles. We will be having all the pearls from last year as well as this year coming up time and again on our platforms on Instagram, Facebook, Twitter, LinkedIn, wherever else you can find them. I did post them on our chat in the website. Also the entire event will be found on our website as a rerun in 48 hours from now. Thank you, everybody. And most important is our next episode will be on September 14th with Blake Williamson as our next star. Thank you so much, guys, and good night. For you guys, good morning. I have a whole day of work.
Thank you.
All right, take care.
Bye, everybody. Thank you.
Thank you.
Bye.